Dr. Ravi sir. Now I request Dr. Navin Thakkar sir to speak on invisible medial instability and distal tumor fracture, a case-based thought process.
Again, thank you, TOSACON, organizer, President Secretary and President Secretary of Warangal Orthopedic Association. Today I visited this temple, great hospitality here. Thank you very much again. So we are going to discuss this thought process. This is a small thought process and we'll be learning together. So I may be asking small questions. So this is the typical picture we see. This is been fixed with this plate. Gradually, over the time, it goes into the varus and gets union. This is the typical problem. So, what do you think the problem, Prasad sir? Here, what was the problem? Is it a short plate? Length of the plate was the problem? Everybody agree? And medial combination. Yeah, this is a typical problem with the medial combination. Then there is a varus. So there is an instability which remain even after the fixation, right? And probably the cause is a short plate, which is what taught to us repeatedly. So now let us see what is wrong here. Short plate. As per the audience, anybody has to differ? Yes, sir. Should I go to the previous slide? Yeah.
From the medial side,
Yes.
you should put a bendable nail there.
Flexible nails on the medial side. When there is a combination, you need some medial support.
Yes.
So there was some invisible instability remain after the fixation, and that was not noticeable on the table by the surgeon. Right? This is a typical problem. So now let us see what is happening here. Now it is okay, sir? Prashad, sir? Do you think the length of the plate is okay, sir? Length of the plate, and as per the principle, screws are divided. Do you want a still longer plate?
No, that medial side support and medial shift is there.
So always, primarily you put medial support? All the fractures?
Reduction is not complete.
Everybody agree? Primarily you put a medial plate in such cases? So surgeon was right here or wrong?
Reduction not there.
Reduction, what is the problem in reduction, sir?
You want to modify the plate. Plate location there is.
Plate location is?
It is stated now, sir. So that's why it is pushing medial.
It is pushing medially, or it is just a combination here? It is aligned, almost aligned.
Plate is not contouring to the bone.
Plate is not contour according to locking plates are contouring?
Sometimes you won't contour.
Yeah. So according to the different anatomy, it may not contour, may contour. But the principle has been used rightly, I think.
There is no gap here. We are not contoured. There is a gap between there.
There is a gap here.
No gap here. So the medial lower fragment is gone medially.
It has gone medially. Okay. No, sir. This is whole combination, sir. Here is the lower fragment and here is the proximal fragment. In between, whole metaphysis has been combinated. Intra-articular part has not been reduced properly. We forget this. We are considering this as far as the length of the plate is concerned, sir.
Need some medial support, sir. Either bone or plate.
Okay. This is what happened gradually. And this is happened. And ultimately it united, but it united the varus. So, what was wrong here? Long plate? No. Not enough stability. So it is not the short plate or long plate. We are taught that you use the long plate, so it will give a good stability and will get a good callus. Right. Another. Again long plate, but surgeon has put a graft, artificial bone, and no structural graft. It was requiring a structural graft. Right. So there is a red flag whenever you see such cases. Is it possible minimally invasive to give a medial support, as Dr. Sir has said? In a crumpled bone or elderly, where there is a minimal combination, but it is an elderly bone, It is a crumpled bone where you can do with the flexible nails. As sir has said, you give a medial support with the flexible nail which goes further and further with a small incision on the medial side, and that will give a medial stability. And here you get a good stability, and this is a small medial incision here, you can see here, and it gives a good function. So the concept is a medial loading. Medially loading is occurring continuously, and that invisible instability, small amount of the instability even after the fixation is remaining. And here this gives the micromotion probably, and that's why it gives some callus good on the medial side. The problem with the locking plate was deficiency of medial callus, right? So if we go further, 16 weeks. Yes, this has been operated by one surgeon. Now it has come to you, sir, Prasad sir. What will you do? 16 weeks. What do you think? It's a short plate that is the problem? Lot of valgus is there. You're right. You're right. But it's not showing any sign of the union here. What will you do at the 16 weeks? Bone graft. Anything else? Medial fixation, right? So it is asking for the stability and the biology both. So small plate on the medial side and the fibula is a structural graft has given a good result without changing the plate on the lateral side. Many suggested that to change the plate to the longer side. But if you add a stability on the medial side, even a short plate will work. So this is the result at 12 weeks, and this is the clinical picture, right? So again the same case. Here surgeon put a non-structural graft and the plate was broken, and there was a cold welding, so it was very difficult to remove also. Titanium implant, again fibular graft and a medial plate, 2 screws or 3 screws below and 2 or 3 screws above. Just give a support on the medial side, and that gives a good result. What is happening here? What will happen, sir? Do you have what will happen? Still there is instability? What will happen? What is the course in such type of fixations? What is the course? What will happen, sir? We'll remove the implant now. What will do the fat? Union will occur or not? It will be a failure. What type of failure it will be, sir? Non-union. Okay, let us see. Usually in these cases, we have to wait for 6 to 9 months after the fixations, because it takes a longer time to consolidate, and you can see that gradually it has consolidated very well. Fantastically consolidated with the added stability. And this is the previous scar, and this is the modified Schwarz-Buckner approach to go medially also together. This is the previous scar, this is the new scar, and this is the fibula, and this is the function. So adding a whatever invisible instability which you are not able to understand on the table, that has to be taken care of. That is the message of medial instability. Now the question comes, many surgeons are asking how far I can go medially. There is a beautiful paper by this gentleman where he has divided this area of the femur where you can go up to here, there is no problem. We go up to here, put a medial plate. If you have good dissection, you can go up to here medially. If there is a combination, you can go medially up to here. So it is safe here. This is the paper. Note down this paper. But it is very important where to put and the length of the plate on the medial side. That is also very much important. Just putting the plate will not do. This is one example where patient was not ready for the fibula, not ready for anything. Then we put an intramedullary plate as a medial support, as a lost implant. You can see here, screws we targeted from here to this hole, and that has given a stability, and that has given a function. So this is also a possibility, but patients should be warned that it will be a lost implant. You cannot remove, just like in proximal humerus. These are all theory. Working length, rigidity of construct, strain, micromotion, we all know. Where to span, how to span, what is the fracture length. But many times it is very difficult to understand on the table for individual fracture, individual case. what is the stress and strain, what is the gray area or what is the zone which is required for that case particularly. We cannot follow completely theory. We can follow the principles. So now, for this problem, the AO had come with this implant that is a flexible screw, far cortical screw, which is flexible. You can see here in this video, it is flexible. So it allows the micromotion and it allows the medial callus also. This has been already tried in the literature of far cortical screw, where there is a sleeve inside here in the screw and that allows the movement. And you can see there is a movement here of the plate on motion, on the axial loading. But this is also not worked. This experiment has been tried multiple times. So surgeon has a dilemma always to reduce the risk plate failure and optimum interfragmentary movement. Surgeon has to balance each case. So we have to learn from the nature also. And this is the new development to have a biphasic plate where the thickness of plate is here is different and there is a slot to get the flexibility. And now no confusion, only 4 to 5 holes are there. So you have to put the screw here, no other holes are provided with this new plate, biphasic plate. This is a new development is coming. But what is the solution? In the future, it may come with the smart implants, stress and strain measuring implants. It will tell you on the table that this is the optimum stress and stress is required for this particular condition on the cyclic loading, or one has to be ready to intervene early with the implant. So we have to learn from the nature to remain the stable, still flexible. These bamboos are stable, still flexible. So we have to learn from the nature. Small announcement. Those who are not members of Indian Orthopedic Association, please become the member of Indian Orthopedic Association. And there are many advantages, particularly to the young members. TOSA has 750 members, but all are not IO members. An invitation for the Amritsar IACON 2022. Contribute your science, showcase your techniques, showcase your innovations, submit the abstract. We have extended the abstract submission line to 15th July. Thank you very much.
Thank you, Dr. Ravi Chandra. Now